Good morning. So today we're going to conduct a simulation with the objectives that we're going to lay out, do a quick review of general and initial ACLS and BLS as you are taught in your previous education as we do every year. So we'll do a quick review of that. In addition, we're going to look for signs and symptoms suggestive of an MI and a patient in an unstable cardiac condition and how we would treat that appropriately, and utilizing any adjuncts as deemed appropriate in the presentation. So the general goal of this is purely to do an initial stabilization of a patient and be prepared to move on to the next steps afterwards and which direction we would need to take them. So your final objective today is to identify the patient's appropriate presentation and conduct appropriate procedures and interventions as necessary for initial stabilization. Do you have any questions? All right. In addition, we're also going to be using several adjuncts to help with this scenario today. One thing that we utilize down here in the lab is our EMS system recording software. So this will allow us to record you guys as we're doing the entire scenario all the way through, and then we'll go back, we'll review the video, and afterwards we'll discuss points and clarify if we met our objectives today, and if there's any learning points that we can take away. And we'll also discuss the patient's physiology, pathophysiology presentations, along with pharmacology and any interventions that we performed, and if there's any additional learning points that we can cover. We'll also talk about what we did good and what we can improve. So does anyone have any questions about the mannequin and how it operates? I think we've conducted a thorough review in previous sessions, so this will be just like any others that we've done in the past. Your patient today is going to be a 56-year-old female patient that presented into the urgent care at the main ER room in Gunderson. She was triaged and put into room 12. And so she is there and waiting, and you two are going to be it. Any questions?
Hi ma'am, my name's Kelsey, this is Tony. What's going on today?
Oh, my chest hurts so much.
Okay. Tony, you want to get her hooked up to the monitor, please? Let's do a 3-lead initially. When did that chest pain start?
About an hour ago.
Okay, were you doing anything when it started?
I was at home just cleaning.
Okay. Can you tell me where that chest pain is?
It's in my back and down my left arm.
Okay. All right.
It hurts.
Can you rate it on a scale of 1 to 10 for me?
It's like a 7.
It's like a 7. Okay. Did you try anything? Do you have anything at home that you're prescribed for chest pain?
Yeah, I take nitro because I had a heart attack
Okay.
years ago, and I took one and I feel worse now.
Okay. Do you feel lightheaded and dizzy?
Very.
Okay. All right. So we're hooking up the monitor. Do we have vital signs? Yes, we do. Heart rate 51, 29, 88 over 32. Okay. Tony, let's get defib patches placed prophylactically. Let's also get an IV established. All right, I'm going to listen to your lung sounds, Joanne. Take some deep breaths for me. All right, lung sounds are clear. Let's go ahead and get a 12 lead as well.
Okay. Oh, I just don't feel well.
Okay.
Oh my.
All right. We have that IV established. Okay. Let's go ahead and while we're getting the 12 lead. Oh, we have the 12 lead. Okay. All right.
Kelsey, I'm going to get her some oxygen.
Yes. Thank you. So we're showing inferior involvement. Can we get a right-sided and posterior? And while we're waiting for that, let's go ahead and I'll get that oxygen on here. Do you want to get 0.5 milligrams of atropine, please?
0.5 of atropine?
Yep. We'll give that IV push. All right, Joanne, we're getting a little bit of oxygen on you. What's going to go on is we're going to give you some medicine to try and bring your heart rate up a little bit because
0.5 of atropine going
it's slow, okay? And we're also going to give you a little fluid that'll hopefully help with you feeling, with your lightheaded feeling, okay?
All right, I'm going to give her a fluid bolus.
Okay, let's start with 500. Lungs are clear.
Okay.
So we're looking at potential right-sided involvement. Do we have that?
Here's your right side.
Thank you. I'm gonna have you take a peek. That's our first left-sided EKG. Okay. All right. Yep, and we're showing elevation.
Yeah.
We're showing right-sided, and we're showing posterior.
Yeah, with this, we're probably gonna have to activate.
Let's give, what's that?
What's that mean?
So it's showing that your part of your heart is not getting enough oxygen. Okay, it's suffering some damage, and that's causing you pain, and it's causing you to feel like this. So we're gonna give you another medication.
Am I having another heart attack?
Yes, you are, ma'am.
Oh,
Okay.
every time.
All right. We're given that fluid bolus.
What do you, when you're saying you don't feel good, what are you feeling, Joanne?
I just feel really weak. I want to throw up. I just don't feel good at all.
Okay. All right. So,
That definitely sounds very convincing for a right-sided
right.
MI.
So stats are 93, heart rate 69, and blood pressure is still correct. So,
Is
okay.
everything okay?
All right, we get some labs drawn.
Yep.
Lab.
Let's activate the cath lab
Yes.
as well. All right, Joanne? Joanne, can you hear me? Okay, so we're starting to have some more breathing difficulty. Let's set up to manage the airway.
Okay.
Okay.
I will get out the meds.
And 46/24. All right, I'm gonna can you grab me a BVM, please?
The BVM right here.
Okay. Joanne, I'm gonna start helping you breathe a little bit, okay? All right, cyanotic. How much fluid do we have in?
We have about 450 right now.
Okay. Let's get another IV established.
Another IV?
Yeah.
Okay. Get the respiratory things. Alright. Second IV is in. Her fingers are really looking bad. She's got quite a lot of sinuses going
Okay.
on. Doesn't have really good cap refill either.
Okay.
She's looking pretty bad. She's in pretty
Is that our rate, or is this our rate?
80.
Okay, rate is 80, and we're hypotensive. Okay.
Very hypertensive.
Okay.
I'm gonna give a second.
Well, heart rate's 80. So, I guess we'll keep doing that fluid and keep ventilating. All right, and she went into VFib. Okay, let's go ahead and dial that up to 150 joules. Yes, please. Sir, why don't you come over on my side and keep doing CPR for me, please? Okay.
I'm gonna charge 200.
Okay.
Charging.
All right.
Everybody
Clear.
Clear shocking. Shock delivered. Resume
Okay.
compressions.
Tony, you take over airway. I'm going to start medications. All right. Good compressions. 1 milligram of epi.
All right, I see the cords.
They need me to stop, or can I keep going?
1 milligram of epinephrine is in.
Get the cap on. Yeah.
Oh, you've got that already? Okay. All right. Good with compressions. We've got an advanced airway in. And end title's 14. Awesome. Okay.
That easy cap, Kelsey.
Oh, it's over here?
It's in there.
In here? Okay.
Sorry,
Okay. Yeah, that's all right.
And if you want to listen to some firm
Yes.
you need a minute to froze.
All right, give me a breath. Present. Present. Abs and epigastric sounds. Tube is in place.
I'll hold the tube for now.
Okay.
So we can get somebody to put a comforter
Okay.
on.
Does cardiology know the patient's condition has changed?
No. Nurse, can you let cardiology give them a call and let them know that the patient's in cardiac arrest now?
I got a 7.5 tube in. It's 23 at the teeth.
Okay. Sounds good.
She feels like she's bagging just fine.
Okay.
Okay.
All right.
How long has it been?
Coming up on 2 minutes.
Thank you.
You can check the rhythm here.
Yeah, about 15 seconds.
Okay.
Yep.
All right.
And we can switch compressors.
Let's go
when
ahead
we're
and
done.
stop. Do a rhythm check. Do we have a pulse with that? Yes, we do. So we have sinus tach, 116. That's our current blood pressure, 48/31. So we're still infusing our fluids at this time.
How can I help?
You want to help Tony get this tube secured?
Here, I'll just pop that.
Yep. I'm just going to pull this off quick. I can have the tube. There we go.
Then just
If you want to, we'll put a capnography on, and if you could re-verify the tube placement.
All right. Breath. Present.
Has anybody heard when
Present.
cath lab team will be down?
I think they're on their way. I don't know. Is cath lab on their way? Yeah. All right.
All right.
We have 2 IVs established.
Mm-hmm.
We have return of spontaneous circulation. We have a 7.5 tube in. We administered a total of
1 milligram of
1
epi.
milligram
No antidysrhythmic was given.
I think we're ready to meet the cath lab.
All right.
All right, now that we've concluded our scenario, we'll go ahead, we'll review the scenario by watching it from the recording software, and then afterwards we'll go ahead and we will talk about everything that happened today and discuss learning points and what we did good and what we could improve.
Okay.
All right, so now they watch it. How do we think that went?
I think it was pretty straightforward. There's a few things I think that it would have been nice if I'd asked for support staff to assist with the intubation, just like being able to pull the stylet for me and inflate the balloon. But it's not something that's unheard of to have to do emergently by yourself anyway. So it's good either way, but would have been nice for me to ask for your assistance in that support staff.
Oh, sure, okay.
Otherwise, I think it was a pretty straightforward presentation as far as the type of MI that we suspected it was, and I'm sure it would confirm what it was.
Okay. Does the scenario seem like it was realistic for the environment that you would have been in the ER? Somebody suddenly presents.
Yeah.
They go down the way you would
Yes,
expect it.
absolutely. Absolutely. Similar. Yeah. That's good.
Okay. So it's happened before in the real environment.
Yes, indeed.
Okay. So let's discuss what was actually going on with her. So what's your diagnosis of, your working diagnosis of what's actually going on with the patient?
Well, so our EKG showed initially a inferior MI, so because of that we suspected that maybe there was some right-sided involvement. So we asked for a right-sided and posterior. We got
Okay.
showed elevation in V4R, V8, and V9. So
It was really
Showing it.
consistent with her presentation,
Right.
her clinical presentation, given with
Right.
that EKG, it was.
So she took a nitro at home.
Yeah.
Now she's hypotensive,
Made her feel
nauseated.
worse. Yeah, so what she needed was some some fluids. She
You couldn't
needed
give
some
it to her fast
preload.
enough.
She
All
needed
right.
some preload, and kind of the physiology of the heart is that it was probably her RCA that was plugged, given her symptoms.
Okay, so obviously she's bradycardic, and
Yeah.
you guys elected to treat her with atropine.
Yeah.
Would you still continue that course knowing what the MI was?
With knowing that she was a RCA, that's what she needs. She's probably have some blood flow that's been deprived. She's probably a right dominant heart, given all of her symptoms and everything. Without having a cath, I wouldn't know that, but
Sure.
clinically, I would pursue that she's having an RCA occlusion. It's affecting
Sure.
her inferior, posterior surfaces, right-sided, and really her taking out her sinus node as well, is why she has her bradycardia. So
Okay.
atropine is the good.
Sure, so obviously this is an ongoing time because she was approximately an hour before she presented to the ER, and obviously she had a rapid deterioration. Do you guys feel that you treated the rapid deterioration appropriately?
Yeah, as quickly as we probably could have in a realistic setting.
Sure.
We're talking 7-8 minutes or so by the time we get everything involved. Try to
Yeah.
talk to her, try to get everything hooked up.
We
Because,
would have time, maybe, establish a second IV, fluids running there, maybe
Sure.
pressure bag on the fluids. Yeah. She
Get
wasn't,
that preload going.
yeah.
okay,
Keep an eye on her respiratory status so that she doesn't get a fluid overload in case she has some type of ejection fraction that we're not aware of or something
Sure.
like that. So, but
Okay.
if she didn't present in our initial clinical assessment with a lot of edema or anything like that, we can probably assume that she's
all right, so we went from bradycardia straight to VFib. We shocked her out of that, responded with 2 minutes of CPR post.
yeah.
Obviously, she remained unresponsive, so the tube was placed, and then cath lab was ready. Do you feel that there was anything else you could have done within that time frame that we could have improved, maybe for patient benefit or your benefit as well?
Yeah, if we would have had time, we would have put an NG or OG tube down, in case there's air in the stomach from CPR being done on her.
Okay.
Labs, I don't know if
Yeah.
we asked about labs,
Sure.
but
Call
we
for
could
lab.
try and see if we can get labs drawn, and then also have some probably ketamine for sedation if she starts.
Sure, okay.
Probably
So other things to think about afterwards
Right.
is
Yeah.
post-ROS, do we need to consider sedation in addition to the transport?
And given that she's already had an arrest, we know she's going to go to cath lab, and
Mhm.
would have been a great time to start prepping a groin, having somebody else prep a groin, getting the site
Sure.
ready,
Yeah.
have things like that
Yeah.
to think about. Make sure that the defib patches are placed appropriately for the cath lab.
Sure. And obviously, as we know, within our facility, sometimes these patients present very rapidly, and at the
Correct.
same time, they're now decompensating very rapidly. So it seems like we obviously were able to treat this patient as we were most appropriate for what resources we had available to us at the time. How do you feel that your communication went as a team?
We work a lot together in a field setting
Okay.
and in clinical settings, and for the purpose of this, we could have maybe talked more, but I thought we had a pretty good closed-loop communication here. When Kelsey would ask for something, I would repeat exactly what she had asked for, so
Sure.
I thought that was good. We do that in the field too, so very strong communications between us.
So good quality closed
Yeah,
loop.
absolutely.
Yeah.
we try to close
Kind
that
of say
loop.
what we're thinking, like,
Yeah.
Sure.
hey,
We think
bradycardic,
out
let's
loud
go
a lot,
down
so.
atropine or
Yeah.
what.
And obviously, that showed very well. How do you feel that your communication was with the patient?
That could have been better. I know it's always hard with the managing.
Mm-hmm.
But
It's
it
just-
was
it's just
good
harder,
here to
it's
have
just
you,
not as
have you talking with
Natural,
us.
like, yep.
So,
Mhm.
that was good to be able to,
And when you asked, like, hey, what's going on? Am I having a heart attack? It was kind of a good reminder, like, I've got it.
Yeah, we were trying to lead you down that
Right,
scenario,
keep her
weren't we?
in the loop. A lot of
Yeah.
stuff is
So.
going on. She's feeling worse. We got
yeah, it is nice to have that interaction.
Yeah.
Which is,
'Cause sometimes our patients, we don't have that benefit because they are already intubated. But
Right.
obviously, we want to seek and maintain good communication.
Yeah.
That's the only thing I really noticed from our facilitator standpoint is that, well, maybe we could improve the patient communication loop
Correct.
a little bit.
Yeah.
Because obviously they're in a very nervous and trialing environment. She's already had one before, and I'm sure it's not her favorite day of the year. So, but is there anything else you guys feel that you can improve on, or went well, or things that we can improve on within the lab or this scenario?
I thought it went well.
Mm.
Pretty straightforward. Very straightforward.
All
Well
right.
presented.
Well, thank you. I think everything went very well.
Thank